Welcome back to Radon Smart Review GI series. This is episode 21, Case-Based Review, Upper GI. Over the last several episodes, we've really systematically broken down the evidence that defines modern GI oncology. Today, we're going to put that knowledge into practice. This session is set up like a comprehensive mock oral board examination. I'll be presenting 5 detailed case blocks. We'll cover esophageal, gastric, pancreatic, hepatobiliary, and hepatocellular cancers. For each one, I'll give you a clinical scenario and then pose some questions, designed to test your knowledge across the core competencies, just like you'd experience in your boards. For you listening, I really encourage you to pause after each question. Try and formulate your own structured response before we give the model answer and highlight the key teaching points. Ready to go?
Absolutely. Ready to dive in and test the knowledge. Let's do this.
Excellent. All right, let's begin with our first block, esophageal cancer. Here's your first patient. A 62-year-old man, significant 20-pack year smoking history. He presents with a 2-month history of worsening dysphagia. It started with solids, now it's progressing to liquids. And he's had a 10-pound unintentional weight loss over that same period. He denies odeomatophagia or cough. An EGD was done, and it confirmed a fungating mass at 25 centimeters from the incisors. Biopsy of this mass revealed invasive squamous cell carcinoma. So given this initial presentation, how do you proceed with his initial workup and evaluation? Could you specifically detail the labs, the imaging, and any necessary procedures you'd order?
Right. Okay, let me organize my thoughts here. So this patient has a new diagnosis of what sounds like a mid-thoracic esophageal squamous cell carcinoma. My comprehensive initial workup it would be multi-pronged. I'm aiming to achieve 3 critical things here. First, accurately staging the disease, both its local extent and any distant metastatic disease. Second, assessing his overall fitness for the multimodality therapies we're likely going to propose, given his presentation. And third, identifying any immediate complications, like, say, severe dysphagia. For the clinical evaluation, well, beyond the standard history and physical, I definitely delve deeper into his dysphagia. Is it truly obstructive to both solids and liquids? That's a sign of pretty advanced local disease. I'd specifically ask about any associated symptoms like odonophagia could suggest ulceration or inflammation or persistent cough, hoarseness, even recurrent pneumonia. These are critical because they could point towards airway involvement, maybe recurrent laryngeal nerve issues, or even a TE fistula. His smoking history, obviously, is a huge risk factor for squamous cell, and it also makes me think about his underlying pulmonary reserve. Okay, moving on to labs. I'd order a CBC, a complete blood count, to check for anemia, which is common with chronic bleeding from these tumors, and also check his bone marrow function. A CMP, comprehensive metabolic panel, is crucial. Need to evaluate his renal and hepatic function that directly impacts chemo choices, and also his electrolytes and albumins is a marker for nutritional status, especially with that weight loss. And specifically for squamous cell carcinoma, it's absolutely standard now to get PD-L1 expression status, usually reported as a CPS, the combined positive score. This information is vital. It's going to guide decisions about integrating immunotherapy later on, especially if he has advanced or metastatic disease. Regarding imaging for staging, I'd start with a contrast-enhanced CT scan. Chest, abdomen, pelvis. This is essential for seeing the primary tumor's relationship to nearby structures, aorta, pericardium, airways, and also for spotting any obvious distant mets, like liver or lung nodules or distant nodes. After the CT, a PET CT scan is definitely indicated. A PET CT is just much more sensitive for detecting distant mets and finding occult nodal disease that the CT might miss. Studies consistently show PET CT upstages nodal disease in up to 30% of patients. That really impacts treatment intent. And then for the best locoregional staging, that's the clinical TNN stage and endoscopic ultrasound, or EUS, with FNA capability for any suspicious nodes nearby, that's mandatory. It gives you that precise look at how deep the tumor goes into the esophageal wall and helps characterize those regional nodes. Finally, procedures. The critical one here is a bronchoscopy. Given the tumor location at 25 centimeters, that's right around the concertina, the T4 landmark. So bronchoscopy is absolutely mandatory to rule out direct airway invasion. That's a T4B finding, right? If it's invading the trachea or main bronchi, that immediately makes him unresectable. I'd also make sure he gets a formal nutritional assessment from a dietitian. Depending on how bad his dysphagia is and his overall status, maybe a prophylactic feeding tube, like a J-tube, or even a temporary esophageal stent might be needed before we even start therapy.
That is an exceptionally thorough and really well-organized initial workup plan. You've clearly laid out not just what you'd order, but why each piece is essential. You linked it directly to the disease's behavior, the anatomy, common spread patterns. That comprehensive approach is exactly what we look for, and a critical clinical pearl for everyone listening, especially for boards. Always remember those 3 essential staging studies for esophageal cancer. You need the CT for the overall anatomy and distant M staging. You need the PET-CT for better sensitivity for occult, distant disease, and nodal upstaging. And you need the EUS for that precise local regional TNN staging. And you absolutely nailed that indication for bronchoscopy. Any tumor at or above the carina, roughly 25 centimeters. That's a high-yield question right there. All right, let's keep going with this patient. His initial workup is now complete. The EUS confirms the tumor invades through the muscularis propria right into the adventia. So clinical T3. He also has 3 suspicious paraesophageal lymph nodes seen on EUS. They were biopsied, confirmed positive. So clinical N1, the CT scan shows partial encasement of the left main stem bronchus, but thankfully the bronchoscopy confirmed it's just extrinsic compression. The mucosa is intact, no direct invasion. However, a big finding for the PET-CT, it reveals an intensely FDG-avid left supraclavicular lymph node. This node was then biopsied by FNA and confirmed metastatic squamous cell carcinoma. And finally, pathology from the primary tumor confirms a PDL-1 CPS of 20. Okay, so based on all these specific findings, anatomical and pathological, and using the AJCC 8th edition for esophageal cancer, what's his full clinical stage? And what does this staging tell us about his resectability for surgery?
Okay, let's stage him carefully using the AJCC 8th edition for esophageal squamous cell. There are some important nuances here, especially with nodal classification. For his T stage, the EUS shows invasion into the adventitia but not beyond, so that's definitively a clinical T3 tumor. It's really important to note, like you said, the CT showed partial bronchial encasement, but the bronchoscopy confirmed no direct invasion, just extrinsic compression. So it doesn't meet the criteria for T4B. T4B would be invasion of things like the trachea, aorta, vertebral bodies, stuff that makes it unresectable because you just can't remove those organs. For his end stage, okay, he has 3 biopsy-proven paraesophageal nodes. Those are regional. And critically, he also has that biopsy-proven positive left supraclavicular node. Now, for thoracic esophageal cancer, the AJCC 8th edition specifically classifies supraclavicular nodes as regional nodal disease, N, not distant Mets, M, M. So with more than 3 positive regional nodes, those 3 paraesophageal plus the 1 supraclavicular, he gets classified as clinical N2 disease for his M stage. Since that supraclavicular node is considered regional, not distant by AJCC, and no other distant metastatic sites were seen on his CT or PET-CT, he's clinical M0. Putting it all together, his full clinical stage is clinical T3, N2, M0. According to AJCC 8, that makes him stage 3B esophageal squamous cell carcinoma. Now, about resectability. Despite being clinically M0, the presence of that positive supraclavicular node conventionally, it typically renders him surgically unresectable. The reason is those nodes are just outside the standard field for an unblocked esophagectomy. Trying to chase those nodes surgically would mean a much bigger operation, way more morbidity, and probably questionable oncologic benefit. But, and this is absolutely vital to emphasize, even though he's surgically unresectable, he is still considered potentially curable with definitive non-operative therapy.
Precisely. That is an absolutely critical high-yield board-testable nuance. You navigated that perfectly. You correctly applied the AJCC rules for supraclavicular nodes and their huge implication for surgical resectability while still keeping the focus on curability. A key clinical pearl for everyone to really internalize. For thoracic esophageal cancer, supraclavicular nodes are regional, not distant, but their presence almost always makes the patient surgically unresectable because they're outside that standard in-block esophagectomy field. That's a classic trap on oral boards. All right, so this patient is well-informed. He's highly motivated for aggressive curative intent therapy. Given his unresectable, locally advanced esophageal squamous cell carcinoma, what are the current evidence-based treatment paradigms you discuss with him? And critically, what would be your definitive recommendation? Make sure to cite the relevant trials and explain how your chosen approach addresses his specific patterns of failure.
Okay, for unresectable, locally advanced esophageal cancer like his, there are basically 2 main evidence-based approaches I discuss with him, outlining the pros and cons. First, there's definitive concurrent chemoradiation, or CCRT. This has, historically been the standard of care for non-operative management. The foundation for this comes from the RTOG 8501 trial. That study showed a big survival advantage for combined therapy. In that trial, the concurrent ARM 50.4 gray radiation with concurrent cisplatin and 5-FU got a 26% 5-year overall survival. That was a huge improvement compared to, 0% 5-year survival with radiation alone. The main problems or patterns of failure with this approach, especially with bulky N2 disease like his, have been both local regional recurrence in the treatment field and, importantly, distant metastatic failure. The second approach, which is increasingly the modern standard, is induction systemic therapy followed by definitive chemoradiation. The rationale here is pretty clear. Give several cycles of systemic therapy up front. This does a few critical things. It tackles presumed micrometastatic disease that we can't see on scans, a big risk with N2 disease. It acts as a sort of biologic stress test, letting us see if the tumor responds to chemo. And it can potentially shrink the primary tumor in nodes, which might make the subsequent local treatment safer and more effective. If the patient responds or stays stable after induction, then they move on to definitive chemoradiation. This sequence specifically aims to hit that high risk of distant failure, which is a major challenge, especially with bulky nodes. My definitive recommendation for this patient, considering his specific findings, especially the high PDL-1 CPS score of 20 in his N2 disease, would be the induction systemic therapy approach. This is strongly backed by the landmark KEYNOTE-590 trial. That trial showed a statistically significant and clinically meaningful overall survival benefit when adding pembrolizumab, the checkpoint inhibitor, to platinum fluoropyrimidine chemo, like FOL-FOX, in patients with advanced esophageal squamous cell and a CPS of 10 or greater. So the sequence I'd recommend is induction FOL-FOX plus pembrolizumab for several cycles. Then, assuming no disease progression, he'd proceed to definitive concurrent chemoradiation. This strategy prioritizes getting systemic control early to address his high distant risk from both the N2 disease and the high PDL1 expression, followed by aggressive local therapy for the best shot at a durable cure.
Very well articulated. You correctly linked the PDL1 status to that modern immunotherapy-containing induction regimen. You justified it precisely with the KEY trial. A critical clinical pearl here. KEYNOTE-590 really is a practice-changing trial for advanced esophageal squamous cell. You absolutely have to be ready to justify adding immunotherapy based on that PDL1 CPS score. CPS 10 or greater is a threshold for pembro plus chemo and emphasize its clear overall survival benefit. This is current standard of care. Okay, moving on. This patient has now completed 5 cycles of FOL-FOX pembrolizumab. Restaging scans show an excellent partial response, significant tumor, and nodal regression. He's now referred to you to plan his definitive radiation. Please outline your detailed radiation treatment plan. Include the simulation setup, dose and fractionation, precise delineation of your target volumes GTV, high-dose CTV, elective CTV, and finally the critical OAR constraints you'd apply.
Okay, my plan for definitive radiation here will definitely use highly conformal techniques, specifically IMRT, intensity modulated radiation therapy. The goal is maximum local control and target coverage while meticulously sparing normal tissues. For simulation setup, I'd position him supine in an alpha cradle for immobilization, arms down by his sides typically. A long mask for head and neck immobilization is needed since his supraclavicular nodes were involved. A 4-DCT with IV contrast is absolutely essential. We need to account for respiratory motion of the esophagus and nearby organs. I'd also do a comprehensive fusion. Take his pre-chemotherapy PET-CT and diagnostic CT scans and fuse them with the simulation CT. This is crucial for accurately drawing the clinical target volume, especially identifying those initial nodal sites and the full pre-chemo tumor extent for elective coverage. For dose and fractionation, the standard definitive dose for esophageal CCOT is 50.4 gray in 28 fractions. That's 1.8 gray per fraction. It's really important to remember that dose escalation trials like INT 0123N or DECO showed no survival benefit for going higher than 50.4 gray, even though they were trying to improve local control. I deliver this using an IMRT simultaneous integrated boost or SIB technique. So the high-risk volume gets the full 50.4 gray, and the elective volume gets 45 gray, which is 1.6 gray per fraction simultaneously. Okay, target volume delineation. This is a critical step. First, the GTV gross tumor volume. This would include the post-chemotherapy residual primary tumor we see on restaging scans, plus all the initially involved lymph node sites that were treated with chemo. That specifically includes that biopsy-proven supraclavicular node. Second, the high-dose CTV, the clinical target volume getting 50.4 gray. This would be typically a 1.5 to 2 centimeter isotropic expansion on the GTV, extending longitudinally beyond the gross disease and involved nodes. This covers microscopic disease right next to the tumor. Third, the elective dose CTV, getting 45 gray. This is a comprehensive volume covering potential microscopic spread and at-risk nodes. This volume must be contoured based on the pre-chemotherapy tumor volume. We need a 3 to 4 centimeter superior and inferior margin along the esophagus, and about a 1.5 centimeter radial margin for radial spread. Critically, this elective volume must also cover all the at-risk nodal basins for a mid-thoracic squamous cell. So paraesophageal nodes from above the carina down to the GEJ, and importantly, the bilateral supraclavicular foci, since this positive node confirms regional involvement there. For concurrent chemotherapy during radiation, I'd recommend the weekly carboplatin and paclitaxel regimen. Carbo dosed at AUC of 2 and paclitaxel at 50 milligrams per meter squared. This is widely used, well-tolerated, effective. Think the cross-trial regimen. And finally, the critical OAR constraints, organ at-risk constraints for safety. For the lungs, aim for a mean lung dose less than 12 gray and the lung V20 volume getting 20 gray or more less than 20%. For the heart, mean heart dose should be kept under 25 gray. For the spinal cord, the absolute maximum dose must be below 45 gray to minimize myelopathy risk.
An outstanding and exceptionally detailed plan that reflects not just textbook knowledge, but a practical guideline-based approach. You clearly integrated complex staging with nuanced treatment planning, a key clinical pearl for everyone. Always be ready to justify why dose escalation above 50.4 gray is not standard for definitive esophageal chemoradiation. Cite the negative INT 0123 in our DECO trials. Shows you really know the evidence. Also, a common board pitfall is contouring that elective volume only on the post-chemo residual disease. You correctly pointed out you have to contour it based on the pre-chemotherapy extent for comprehensive coverage. All right, let's say the patient successfully completed his treatment. He had manageable grade 2 esophagitis, which is pretty common. What's your comprehensive plan for his follow-up? And what are the expected long-term outcomes and potential complications you'd counsel him on?
Okay, for a non-operative patient treated definitively for locally advanced esophageal cancer, surveillance has to be rigorous, really systematic, to catch any local recurrence or distant mets early. For the initial response assessment, I'd recommend a PET-CT scan about 3 months after he finishes radiation. That timing is deliberate. It allows for any delayed tumor regression to happen and lets post-treatment inflammation cool down, minimizing false positives. We're hoping for a complete metabolic response. For ongoing surveillance after that first scan, he'll need regular imaging. Typically CT chest and abdomen every 3 to 6 months for the first 2 years. After that initial intensive period, we can probably space it out to annually up to 5 years. Any new or worsening symptoms, especially if dysphagia returns or new respiratory symptoms, that triggers an immediate EGD with biopsies of anything suspicious. We might also do endoscopic surveillance with biopsies of the treated area anyway, regarding expected long-term outcomes and patterns of failure. While for unresectable, locally advanced esophageal squamous cell, even with modern aggressive therapy, including immunotherapy, the prognosis is still guarded. But it's definitely considered potentially curable. His expected 5-year overall survival, based on current data, is probably in the range of, say, 35 to 50%. The primary pattern of failure, despite good local treatment, is still distant metastasis, often liver or lungs. That reflects the systemic nature, especially with N2 disease. However, local regional recurrence within the treated field or nearby nodes still happens in a significant number, maybe 30 to 40%. As for potential long-term complications from his treatment, well, the grade 2 esophagitis during treatment is common acute toxicity. Long-term, he's at risk for esophageal stricture due to radiation fibrosis. That might need endoscopic dilatation. He's also at risk for radiation pneumonitis, inflammation in the lungs, and maybe pericarditis, inflammation around the heart given the treatment location. Careful monitoring for these late effects is essential.
All right, that wraps up our first comprehensive case. You handled that challenging esophageal scenario exceptionally well, showed a robust understanding of staging, modern treatments, and follow-up. Let's switch gears completely. Here's your next case. A 68-year-old man, otherwise fit, who presents to his primary doctor with vague epigastric pain. It's been intermittent for about 4 months. Also has early satiety and a 10-pound unintentional weight loss over the past 2 months. An EGD was performed, confirmed a 4-centimeter ulcerated mass in the gastric antrum. Biopsy confirms a poorly differentiated intestinal-type adenocarcinoma. Based on this presentation, what's the rest of your staging workup? Detail the specific imaging and procedures you'd order, and crucially, explain the rationale for each choice.
Okay, this presentation is highly concerning for a gastric malignancy, obviously. My comprehensive workup would aim to confirm the diagnosis, accurately establish the local and distant extent of disease, and also assess his overall fitness and nutritional status for potential therapies. For initial labs, I'd get a CBC checking for anemia from possible chronic GI bleeding and bone marrow function. A CMP is essential for baseline renal and hepatic function, vital for chemo planning, and albumin levels for nutritional status. I'd also get a baseline CEA tumor marker. Its utility in gastric isn't always perfect, but it can be helpful for monitoring therapy response sometimes. For imaging, a contrast-enhanced CT of the chest, abdomen, pelvis with both oral and IV contrast is absolutely essential for M-staging. I'd be looking very carefully for distant Mets liver, lungs, distant nodes like celiac, periaortic, supraclavicular, and I'd specifically request a pancreatic protocol CT with triphasic imaging arterial, portal venous, delayed phases. That gives the best look at the tumor's relationship to adjacent organs like the pancreas and helps spot subtle liver Mets. For precise locoregional staging, especially T-stage depth of invasion and end-stage local nodes, an EUS endoscopic ultrasound is very helpful. High-resolution imaging of the gastric wall plus FNA capability for suspicious nodes. And now, the critical procedure often missed for gastric cancer. I would strongly recommend a diagnostic laparoscopy with peritoneal washings. This is truly essential to rule out occult peritoneal mets. Microscopic disease can be missed on even good CT scans in up to 30% of cases. Finding peritoneal mets would immediately make him ineligible for curative resection, completely changing management to palliative. So diagnostic laparoscopy is mandatory for potentially resectable gastric cancer.
Excellent. You've clearly laid out the crucial workup components for gastric cancer, especially highlighting that critical role of diagnostic laparoscopy, a key clinical pearl for residents. For gastric cancer, diagnostic laparoscopy is a pivotal staging step, often missed on boards. Peritoneal mets are common, often occult on imaging, making this procedure indispensable for determining resectability. All right, the workup for our patient is now complete. Imaging, including that diagnostic laparoscopy, shows a thickened gastric wall consistent with clinical T3. Several enlarged perigastric nodes were biopsied, confirmed positive, so clinical N1. No evidence of distant metastatic disease on CT or the diagnostic laparoscopy peritoneal washings were negative. Patient has an excellent ECOG performance status of 0. At the multidisciplinary tumor board, what is the standard of care for this resectable, locally advanced gastric adenocarcinoma? And what are the expected patterns of failure?
Okay, for a medically fit patient with resectable clinical T3N1 gastric adenocarcinoma, the standard of care is definitively a multimodality approach. It centers on perioperative chemotherapy and surgery. For systemic therapy, I would strongly recommend the FLOT regimen. That's fluorouracil, leucovorin, oxaliplatin, and docetaxel. Typically, it's 4 cycles before surgery, the neoadjuvant part, and then 4 cycles after surgery, the adjuvant part. This is strongly evidence-based, mainly from the FLOT-4 trial. That big phase 3 trial showed superior median overall survival 50 months with FLOT versus 35 months with the older MAGIC regimen. Giving chemo upfront treats micromets early, tests tumor biology, and can potentially downstage the tumor, improving the chances of getting clear margins and R0 resection. For surgery, it should be a subtotal gastrectomy for an antral tumor combined with a formal D2 lymph node dissection. The goal of the D2 dissection is to remove all perigastric nodes plus nodes along the major arteries, aiming for at least 15 lymph nodes for proper staging and clearance. This standard comes from long-term follow-up, like the Dutch D1-D2 trial, which showed better long-term outcomes with D2 dissection. Regarding expected patterns of failure for gastric adeno, well, despite this aggressive approach, both locoregional recurrence, usually in the gastric bed or regional nodes, and distant recurrence are common. Distant recurrence often shows up as peritoneal carcinomatosis, which is particularly tough to control, or liver metastases. The aggressive biology really necessitates this combined approach.
That is the perfect comprehensive answer. You nailed both the modern systemic therapy standard from FLOT4 and the surgical standard of a D2 dissection from the Dutch D2 trial. Shows real understanding. A key clinical pearl. FLOT chemotherapy plus a D2 dissection is the modern guideline recommended standard for resectable gastric cancer in the West. Now for a twist. A common scenario we see on boards. Imagine this patient instead has an upfront subtotal gastrectomy at an outside hospital before coming to your tumor board. The surgeon only performs what's documented as a D1 dissection, retrieving 10 lymph nodes. Final path, pathologic T3N1, margins negative. He now presents to your clinic for adjuvant therapy recommendations. How does this specific surgical history change your plan? And what's the precise rationale, citing the evidence?
Okay, this scenario completely changes the management. The patient had an inadequate lymph node dissection, a D1 with only 10 nodes. That's below the recommended 15 plus for a D2. This suboptimal surgical staging and clearance puts him at a significantly higher risk for locoregional recurrence. So in this specific situation, suboptimal D1 dissection adjuvant chemoradiation is definitively indicated. My primary recommendation would be based on this landmark INT-0116 trial, McDonald trial. That pivotal trial showed a significant overall survival benefit for adjuvant chemoradiation in patients with gastric cancer who had undergone a D0 or D1 dissection. Median OS was 36 months with chemoradiation versus 27 months with surgery alone. The clear rationale for adding chemoradiation here is to compensate for that inadequate nodal dissection. By giving postoperative radiation to the gastric bed and regional nodes, we aim to kill any microscopic residual disease not removed surgically. This addresses the high risk of locoregional recurrence from the incomplete surgery, hopefully improving his long-term outcome.
Exactly right. That's a classic high-yield board scenario. The quality of surgery D1 versus D2 fundamentally dictates the role of adjuvant radiation in gastric cancer. Your understanding of the McDonald trial's direct relevance is key. Building on that, please outline the precise postoperative clinical target volume, or CTV, for this PT3N1 adenocarcinoma of the gastric antrum that had a D1 dissection. What specific anatomical structures and nodal basins must be included in your CTV, given his surgical history, and what's your typical dose in concurrent chemo?
Okay, the CTV for this patient needs to be comprehensive. It has to meticulously cover both the tumor bed and, crucially, those at-risk D2 nodal regions that weren't adequately addressed by the D1 surgery. For the tumor bed component, I'd contour the gastric remnant and, importantly, the gastrojejunectomy and anastomosis. That anastomosis is a known common site for local recurrence after gastrectomy, so it needs careful coverage. For the nodal volumes, the CTV must cover all the uninvolved D2 basins that should have been cleared but likely weren't. That means the celiac axis nodes, the porta hepatis nodes, and the pancreatico-duodenal nodes. For a distal antrum tumor like his, splenic hilum nodes could probably be omitted unless there was specific involvement or a really large tumor extending that way. Additionally, the CTV needs to extend inferiorly to cover the para-aortic nodes down to maybe L2 or L3 level, ensuring comprehensive regional coverage. For the typical dose and concurrent chemo in this adjuvant setting, based on McDonald, standard radiation dose is 45 gray in 25 fractions. This would be given concurrently with either continuous infusion 5-FU or oral capecitabine. Those were the chemo agents used in that trial.
That's a well-defined and accurate CTV description. Exactly what's needed for this challenging post-op gastric scenario. You clearly identified the critical structures and nodes to cover due to the suboptimal surgery. All right, next scenario. Your patient is a 67-year-old woman presenting with painless jaundice classic for a pancreatic head mass. A pancreatic protocol CT reveals a 3-centimeter mass in the head of the pancreas. The critical finding. This mass demonstrates abutment of the superior mesenteric artery, the SMA, along exactly 90 degrees of its circumference. Crucially, no frank encasement. Based on these imaging findings and NCCN guidelines, what's the resectability status, and what's your recommended initial management strategy? Justify your assessment and approach.
Okay, based on NCCN guidelines for pancreatic adenocarcinoma, tumor abutment of the SMA of less than or equal to 180 degrees without frank encasement defines this as borderline resectable pancreatic cancer. It's worth quickly remembering other criteria for borderline. SMA abutment equals 180 degrees, or portal vein SMV involvement 180 degrees, but still reconstructible by an experienced surgeon. Her 90-degree SMA abutment fits right in. For this diagnosis, borderline resectable, the unequivocal standard of care is a neoadjuvant approach, treatment before surgery. The primary goal is to maximize the chance of an R0 resection, clear margins microscopically. That's consistently the single most important predictor of long-term survival in pancreatic cancer, so I'd recommend initiating systemic chemotherapy up front. For a fit patient, the preferred regimen is FOLFIR-INOX, that's fluorouracil, leucovorin, irinotecan, and oxaliplatin. This recommendation comes from strong evidence, especially extrapolating from the adjuvant PRODIGE-24 trial, which showed superior OS with FOLFIR-NOX in the adjuvant setting. Giving this potent chemo upfront also treats potential micromets, can induce tumor regression, potentially making resection easier, and acts as a valuable biologic stress test to see how the tumor behaves.
Correct. You precisely defined the resectability status based on NCCN criteria for arterial involvement, a crucial clinical pearl. That distinction between arterial abutment, 180 degrees, and frank encasement, 180 degrees, is a classic board question, defines resectability and dictates initial management. For any borderline resectable pancreas cancer, the paradigm is always neoadjuvant therapy first, never upfront surgery. Fundamental principle. Okay, this patient now completes 4 months of FOLFIRI-NOX. Restaging scans show a good partial response, significant tumor regression. She's now referred to you to discuss the potential role of consolidative radiation before a potential surgical exploration. How do you counsel her about the evidence for adding radiation here, and what would you recommend?
I'd counsel her that even after a good response to induction chemo, there's still a significant risk of a positive surgical margin, especially in those perivascular tissues where the tumor initially abutted the artery. Consolidative radiation therapy given before surgery can play a crucial role. It helps further sterilize the tumor bed and those critical perivascular tissues. This increases the chance of getting that clean R0 resection, the most important factor, and improves local control. Regarding the evidence, it's important to provide context. The LAP-07 trial didn't show an OS benefit for conventional chemoradiation in unresectable patients, but that used lower doses. In contrast, the PREOPANC-1 trial, focused on borderline resectable patients like ours, did show a survival benefit for neoadjuvant chemoradiation compared to upfront surgery. So that supports a neoadjuvant approach. And furthermore, more recent phase 2 data, like from the SMART trial, have shown excellent local control rates using high-dose SBRT, stereotactic body radiation therapy after induction chemo. This really sets the stage for highly focused ablative radiation. This evolving evidence provides a strong rationale for proceeding with consolidative radiation in her case. My definitive recommendation would be for consolidative SBRT before surgical exploration.
Very good. You clearly articulated the rationale and cited the evolving evidence, distinguishing the trial contexts. Shows a nuanced understanding. Now, please outline your SBRT plan. Simulation setup, dose, fractionation, precise volumes, GTV, CTV, PTV, and crucial OAR constraints specific to the pancreas.
Okay, my SBRT plan would be meticulously designed for an ablative dose while strictly protecting nearby critical organs. Simulation setup. Supine, arms up on a wing board for immobilization. A 4DCT is absolutely essential for respiratory motion. I'd specifically use an expiratory breath hold technique for the planning. CT gives a consistent, reproducible tumor position. IV contrast is essential too, for visualizing tumor, vessels, organs. Dose prescription. I prescribe an ablative dose. We want a biological effective dose, or BED, using an alpha beta of 10 for tumor greater than 100 gray. A common effective SBRT regimen for pancreas is 40 gray in 5 fractions, usually over 1 Rent. That gives a BED 10 of 80 gray. Target volume delineation. First, GTV, gross tumor volume. Precisely contour the post-chemo residual tumor and any involved nodes on the latest restaging scans. Use fused MRI or diagnostic CT for this. Second, CTV, clinical target volume. This includes a small, tight CTV around the GTV plus any remaining tumor vessel interface. Critically, it also includes a perivascular CTV encompassing that triangle volume around the celiac axis and SMA. That region is important common pathway for perineural spread, frequent site of microscopic disease, and local failure. Third, PTV, planning target volume. Typically the CTV plus a very small, tight margin, maybe 2 to 3 millimeters, for setup uncertainty and any residual motion not fully managed by breath hold. Critical OAR constraints. The most paramount concern in pancreas SBRT is the duodenum. Close proximity, sensitive to high dose. We must respect a hard constraint. The volume of duodenum getting 33 gray, V33, must be less than 1 cubic centimeter, less than 1 cc. For kidneys, aim for mean dose less than 18 grays each. Liver, mean dose less than 30 grays. Spinal cord, absolute max dose below 45 gray.
That's an exceptionally precise SBRT plan. Clearly shows understanding of the technical details and safety priorities. The focus on the duodenal constraint and the CTV rationale are excellent. Now let's move to hepatocellular carcinoma, HCC. Your patient, 65-year-old man, Child-Pugh A cirrhosis, presents with a new, rapidly progressive liver lesion. Diagnostic imaging, a multiphasic MRI liver reveals a large 8-centimeter HCC. Critically, with clear macrovascular invasion, MVI, involving a portal vein branch. What's his resectability status based on BCLC staging? And what's your recommended initial management? Detail the staging and justify your approach.
Okay, HCC case. For resectability status, the presence of macrovascular invasion, MVI, involving a portal vein branch. That immediately puts him in Barcelona Clinic liver cancer, BCLC, stage C, advanced HCC. Unfortunately, because of the MVI, this makes him surgically unresectable. Also makes him ineligible for liver transplant or primary local ablation like RFA. For initial management given BCLC stage C, the unequivocal standard of care is first-line systemic therapy. My definitive recommendation would be the combination of editazolizumab plus bevacizumab. This is based on the groundbreaking EMBRAVE 150 trial. That pivotal phase 3 trial showed superior overall survival with atezobev compared to sorafenib, the previous standard. The clear rationale is to improve systemic control, target the widespread nature often indicated by MVI, and ultimately extend overall survival for advanced HCC. It combines immunotherapy and anti-angiogenic therapy.
Correct. Macrovascular invasion immediately makes him BCLC stage C, requiring first-line systemic therapy. fundamental HCC board principle. All right, this patient responds very well to achelazumab and bevacizumab. You're now asked to evaluate him for consolidative SBRT to the primary tumor to improve local control. What's the evidence supporting integrating radiation here, especially after systemic therapy? And what are the key planning considerations for liver SBRT, including precise OAR constraints for liver and other critical structures?
Okay, evidence for consolidative radiation, specifically SBRT, with systemic therapy for advanced HCC. The key trial to cite is NRG/RTOG-112. This pivotal phase 2 trial showed a statistically significant improvement in overall survival when adding SBRT doses were 27.5 to 50 Gray Z in 5 fractions, concurrently with sorafenib in advanced HCC patients. A significant number of those patients, like our current case, had macrovascular invasion. So this trial gives a strong clinical rationale for combining aggressive local therapy, SBRT, with modern systemic agents to optimize outcomes and get robust local control. Key planning considerations for liver SBRT simulation. Supine, arms up on a wing board for immobilization. 4D CT is absolutely essential for respiratory motion. Again, I'd use expiratory breath hold for the planning CT for reproducibility. IV contrast is crucial for delineation. It's important to note, unlike some other sites, fiducial markers generally are not put in HCC patients. Too much bleeding risk and cirrhosis. Instead, motion is usually managed via diaphragm tracking, or if they've had TACE before, we can sometimes track existing lipiodol. Dose prescription. For a large lesion like this 8 centimeter one, an ablative dose, BED 10 greater than 100 Gray would be appropriate. A common regimen is 45 Gray in 5 fractions. Target volume delineation. GTV is the visible tumor on fused multiphasic CT, MRI, or PET-CT, including the main lesion, and the MVI-PTV is usually derived from an ITV, internal target volume, which accounts for the full respiratory motion of the GTV, plus a small, tight margin, maybe 3 to 5 millimeters, for setup uncertainty. Critical OAR constraints. The single most critical constraint in liver SBRT is sparing enough uninvolved liver to prevent RILD, radiation-induced liver disease. Per Quantac guidelines, widely accepted, we must spare at least 700 cubic centimeters of uninvolved liver to a total dose less than 15 grays. That's a hard constraint, absolutely essential. Other key constraints. Stomach and duodenum aim for Dmax less than 40 gray and V33 less than 1 cc. Kidneys mean dose less than 18 gray if they're in the field.
Excellent. You cited the pivotal NRG-RTOG-112 trial, crucial for justifying combined modality therapy in advanced HCC, and you meticulously detailed the critical safety measures for liver SBRT, a key clinical pearl. Remember, the single most important constraint is the volume of functional liver spared. 700 cc getting less than 15 gray. Threshold for classical RILD. Also, always be able to describe RILD itself. Typically atticuric hepatomegaly, elevated alkalophus, usually within 3 months post-treatment. Now consider a slightly different HCC patient, 60-year-old man, child-POS cirrhosis, found to have a solitary 2.5 centimeter HCC in segment 8. He is not a surgical candidate due to severe portal hypertension. What are his primary ablative options? And what would you recommend, specifically justifying based on comparative efficacy data?
Okay, this patient has BCLC stage A HCC early stage disease. Since he's not a surgical candidate due to portal hypertension, his main ablative options for local control are radiofrequency ablation, RFA, and stereotactic body radiation therapy, SBRT. Given his specific tumor size of 2.5 centimeters, I would definitively recommend SBRT. My justification for preferring SBRT over RFA here is based on strong comparative efficacy data, specifically the WALL study published back in 2015. That study showed superior local control rates for SBRT compared to RFA for HCC tumors larger than 2 centimeters, which includes his 2.5 centimeter lesion. This better efficacy of SBRT for larger lesions is likely because it overcomes the heat sink effect. That can limit RFA effectiveness in tumors near large blood vessels. The heat sink effect is when blood flow whisks away the heat from RFA, leading to incomplete ablation. SBRT, being non-thermal, isn't affected by this, allowing more robust ablation, especially near vessels.
Excellent distinction and justification. That heat sink effect is a critical concept comparing RFA and SBRT in the liver, and the WALL data gives clear guidance. All right, moving to our final patient scenario today, biliary tract cancer. Your patient undergoes resection for a hilar cholangiocarcinoma, a Klatskin tumor, final pathology, pathologic T2N1 tumor with a positive surgical margin, R1 resection. Please describe the expected patterns of failure for this specific pathology, and then give your full recommendation for adjuvant therapy, including specific modalities and the key trials supporting your recommendations.
Okay, hilar cholangiocarcinomas, Klatskin tumors. Their highly infiltrative nature is really the defining thing. They're notorious for having a very high rate of locoregional failure. Some series report rates approaching 60%. It's mostly due to that infiltrative growth around the complex biliary tree and nearby nerves and vessels. This pattern of failure is a critical distinction compared to, say, gallbladder cancer, which tends to fail more distantly, like peritoneal carcinomatosis or liver mets. For adjuvant recommendation, this patient has two very high-risk features post-resection: positive nodes N1 and a positive margin R1. Given these high-risk features, my recommendation would be for a comprehensive multimodality adjuvant approach. That includes both systemic chemotherapy and adjuvant chemoradiation. For systemic chemo, based on the landmark BILCAP trial, 6 months of adjuvant capecitabine is the established standard of care for resected biliary tract cancers, including cholangio. BILCAP showed a significant disease-free survival and overall survival benefit in its per-protocol analysis for patients getting adjuvant capecitabine versus observation for chemoradiation. Given his positive margin and N1 status, adjuvant chemoradiation is strongly indicated. This is supported by evidence from trials like SWOG S0809. That was a phase 2 study showing promising 2-year overall survival 65% with adjuvant gemcitabine and capecitabine, followed by radiation with concurrent capecitabine for high-risk resected biliary cancers. The clear rationale is to rigorously target any microscopic locoregional disease left behind after surgery, especially at the R1 margin and in regional lymphatics, to reduce that high risk of local failure inherent to Klatskin tumors.
Perfect. You precisely identified the expected failure patterns for hilar cholangio and provided a comprehensive, evidence-based adjuvant plan. For biliary cancers, that combination of positive nodes and positive margins is indeed a classic high-yield indication for adjuvant chemoradiation. You correctly identified the two key trials, BILCAP and SWOGS 0809, defining modern adjuvant management. Excellent work. All right, that concludes our extensive case-based review of upper GI and hepatobiliary cancers for today. You've done a fantastic job working through these challenging, nuanced scenarios. Really showed a strong grasp of current evidence in clinical decision-making. Let's briefly recap some key principles and takeaways. From the esophageal case, remember that critical nuance. Supraclavicular nodes are regional, but typically make a patient surgically unresectable. Paramount. For gastric, we saw how surgical quality D1 versus D2 fundamentally dictates the role of adjuvant RT, based on McDonald. In pancreas, the principle. Borderline resectable always gets neoadjuvant therapy first, never upfront surgery, aiming for R0. For HCC, macrovascular invasion means first-line systemic therapy, and those critical SBRT liver constraints, especially the 700 cc 15G rule. And finally, biliary. Positive margins plus positive nodes is a clear, high-yield indication for adjuvant chemoradiation to fight those high local failure rates.
I agree completely. The main principles I'm taking away are the consistent importance of a truly multidisciplinary approach for these complex GI cancers. Every specialist needs to contribute. Also, the absolute necessity for accurate, meticulous staging to guide treatment, relying on robust, evidence-based decision-making, constantly integrating new trial data, and finally, that meticulous attention to technical detail and treatment planning, especially for radiation, to maximize effectiveness while minimizing toxicity. These cases really hammer home the clinical application of all that knowledge.
Absolutely. Great job working through these challenging scenarios. That wraps up our case-based review of upper GI and hepatobiliary cancers for this session.
Thanks. This was really helpful for board prep. It's invaluable to work through these cases in real time like this.
You got it. For all our listeners, you can get show notes and complete practice oral boards at radonsmartlearn.com and subscribe to Radon Smart Review for our next episode. Next time, we'll do the same for the lower GI tract with a case-based review covering challenging cases in rectal and anal cancer. Thanks for tuning in.